Okay, so let's start with stroke. Let's look at table 62-1 to compare the two main types of stroke. We've got ischemic and hemorrhagic stroke. Now, ischemic can be thrombotic or embolic stroke. What does ischemia mean? It's a blockage of blood flow, right? So something is blocking the blood flow, preventing oxygen from being delivered to tissues. So this is on the brain. Now there are two carotid arteries, so they branch off the aorta. They supply the brain, so they are the main arteries going to the brain. So in ischemic stroke, both embolic and thrombotic are caused by a blood clot. Now, what makes the two differences is when we say thrombotic, the blood clot formed inside either carotid arteries or in one or more cerebral arteries. Okay, that's where the clot formed. So what do you think is the risk factor? Why would a clot form in the carotid or cerebral arteries? What formed first? No, before the clot formed, atherosclerosis. Okay, so years of drive-through, okay, years of stress, for instance, form the clot. So risk factors would be hypertension, high cholesterol, metabolic syndrome, diabetes, sedentary lifestyle, obesity, name it, smoking. Okay, so those are your there's no really there's no difference from, remember acute coronary syndromes, risk factors for acute coronary syndromes, the same exact risk factors, because this is just another artery. So in CAD, we were talking about coronary arteries. This time we're talking about cerebral and carotid arteries. So it's just another artery affected by atherosclerosis. And because of the narrowing of the artery, then we invite weakness. And then once the endothelial layer of the atherosclerotic artery breaks or ruptures, then it will attract clots. Then you have an instant stroke. Okay, so we call it again thrombotic stroke if the clot formed right there in the carotid or cerebral arteries. So therefore, since it formed there, is the evolution of the stroke slow or acute? Slower, right? Slower, because the clot will take time to form, right? It'll take a few minutes, it'll take a few hours for the clot to form. Now, in the other type, which is embolic, this author specified cardiogenic because that's really true. In embolic stroke, what is an embolus? A traveling clot. Okay, so therefore, did the clot, if it's an embolic stroke, did the clot form in the carotid or cerebral artery? Somewhere else. Now, that somewhere, 90% of it is actually from inside the heart. So name cardiac conditions that will cause a clot to form inside the heart chambers. Well, pericarditis would be, pericardium is inflamed, so not likely. Atrial fibrillation, atrial flutter. What about heart valve problems? Yes. What about heart failure? Yes. So any condition that causes congestion inside the heart chambers, whether caused by an electrical conduction problem such as dysrhythmias, or let's say general failure of the heart to pump. So any congestion of blood, then a clot will form inside the heart chambers, and it's just a matter of which side. So let's see first. So if a clot forms on the right side of the heart, which organ or which arteries will it block first? Trace the flow of blood. If a clot forms on the right atrium or right ventricle, where will that clot end up? In the pulmonary arteries first. So that's our next topic. We'll talk about pulmonary embolism, hopefully next week. So what if it forms on the left side, left atrium or left ventricle? Where will that clot end up in? True, but which organ will it reach first? Stroke. Okay, so embolic strokes occur if a clot forms from the left side of the heart. Can it also form from the legs? Yes, you get a DVT in one or both legs, then that clot if it misses the pulmonary arteries, then it'll end up in the brain. All right. So any question about embolic and thrombotic stroke? Okay, so they're both ischemic stroke, treated the same way because they're both clots, but we just the treatment and management, of course, will vary because let's say it's embolic stroke. So therefore, which besides a neurologist, who is also consulted to manage the case? If it's an embolic stroke, knowing that 90% are cardiac in nature, a cardiologist will see the patient. Are we clear? All right. So in thrombotic stroke, will it make any difference? Will it be another consultant? Same, and a cardiologist will also see the patient. So therefore, ischemic stroke patients are handled by two specialists. So there's a cardiologist on board because there's an atherosclerotic issue, there's a clotting issue, and then there's the neurologist. Okay, and we'll talk about sometimes we will have conflicting priorities here. Okay, we'll explain later as we go to the autoregulation of the brain circulation. Hemorrhagic, there are three main causes here. So the patient is bleeding. So what's the difference if ischemic stroke, a clot blocks circulation to brain tissue versus a blood vessel ruptured? Why is it still considered a stroke? Still the same thing. So once a one or two or more blood vessels in the brain rupture, that means whichever parts of the brain that artery was supposed to supply with oxygen is not getting it anymore. So it's still the same. The brain tissue does not get any oxygen. The problem with hemorrhagic strokes is there's two types of damage done. Besides the lack of oxygen flow, the bleeding occupies space. So now it will cause more ischemia because now the intracranial pressure rises because of the bleeding. The bleeding occupies space, and therefore, have I told you about the cup of water? No? Okay, I'll just explain shortly. So when you have, let's say, a cup of water, right here, this bottle of water. So let's say I fill that with water, then up to the top right here. So let's say it's filled to the brim, and I add one more drop. What will happen? What overflowed? The one I dropped or something else? Okay, whichever water molecules are closest to the edges, right? Not necessarily what the new drop I added, correct? All right. So consider this the skull now. What are the three things? There are only three things inside the skull. We got brain tissue in there, there's blood in there, and there's also cerebrospinal fluid. So that occupies 100%, correct? Yeah. So if just like this bottle of water or a glass of water, if I add one more, which is now the bleeding, so the hematoma that forms after hemorrhagic stroke, or the same issue with brain trauma, for instance, head injury, same thing. So if any of the three components, so we have about 80% of the skull contents is brain tissue, 10% blood, 10% CSF. So if any one of those components increase in volume, it's already 100%. Can we add one more there? No. So therefore, what happened to this bottle of water when you added the drop? Something overflowed, right? It wasn't what you added. So therefore, in the same idea, inside the skull, if you add a hematoma there from the bleeding, Will the hematoma come out of the skull? So here in this bottle of water, we know where the opening is, right? It's only right there on top. Now, in the skull, where is the only opening? No, the skull, okay, knowing an adult skull, okay, so our skulls, we are adults. Do we still have openings in the suture lines or anything? No. I know we have eye sockets, but are they really open? No, okay, because there's the eyeballs there. Can we come out of the ear? No, because there are sinuses there. Okay, there are other structures there, so that's not gonna come out. So what's the only opening in the skull? The foramen magnum, the base of your skull where your spinal cord exits, right? So that's the only opening in the adult skull. So therefore, just like the idea here, you added a drop of water, you said something will spill, not the water, not the drop I added, but something else closest to the opening. So in the skull, what is closest to the opening? You can't push out the spinal cord, it's already out. So which other brain structure is closest to the opening, just like this bottle of water? The brain stem. Okay, so the base of the brain stem, which happens to control what? What does the brain stem do? Vital functions. They control breathing, circulation, heart rate, blood pressure, controls everything. The site of consciousness is also there, the reticular activating system. The fact that we're conscious right now, we're awake, is because of the reticular activating system. So therefore, if a patient suffers a massive hemorrhagic stroke, what will be the first symptom? Change in the level of consciousness, right? Because the brainstem will be pushed out of the foramen magnum. So suffocating the brainstem, because which one's bigger, the brainstem or the opening? The brainstem's bigger. So if you push a squishy brain tissue out through a much smaller opening, what will happen? So let's say I push out Felicia out into a thermos. What will happen if I force Felicia into a thermos? Well, not you entirely, okay? But you're not brain tissue. Okay? You're made of something else. But a squishy, soft brain tissue. I mean, you've seen brain tissue, right? You've seen a chicken or a pig or a cow brain tissue. You saw what it looks like? It's fat. Yeah, so soft. So if you squish it out, is it going to come out? It will come out. It's very small. But what happens to its circulation? Because now you squeezed a chunk of this into an opening this big. It's going to get incarcerated, right? It's going to get strangulated. So therefore, you will restrict blood flow to the brainstem. So therefore, there will be mental status changes. What happens to your respiratory rate? There's no blood flow to the brain. Everything will drop, right? Okay, so let's look at the risk factors now. So what kind of patients will suffer a hemorrhagic stroke? Okay, those with cerebral aneurysms. What is an aneurysm? So this is a weakening of the artery. So there are 3 layers of an artery, right? We've got the endothelium, we've got the intima, and then we got the muscle layer. So the first 2 layers are weakened. Risk factor usually atherosclerosis again and hypertension. So it weakens the artery. Now the artery looks like this. Okay, so it weakens the wall. The third layer is intact. Okay, but the body is weakened. So if the hypertension continues, what will happen to that artery? It's gonna rupture, causing bleeding. So the first risk factor is hypertension, of course, uncontrolled hypertension, and that can either cause an aneurysm or an AVM is different. Although AVMs will rupture because of hypertension. So what is an AVM? So this is a congenital usually. It forms during your uterine life. So as when you were an embryo or fetus, you develop an AVM. So this is a abnormal network of blood vessels wherein an artery is connected directly to a vein. Remember fistulas or hemodialysis, kind of like that. But unlike the fistula was created by the surgeon, this one was created by nature. So the patient doesn't have a network of capillaries in this particular connection, because an artery and a vein, are they normally connected? No, it's supposed to get smaller and smaller and then becomes a capillary and then enters the venous circulation, right? That's how it's supposed to work. But here, the AVM forms wherein an artery becomes a vein directly with no capillary buffer. Okay, there's that absence of a capillary. So therefore, are veins and arteries made the same way? Which one's weaker, the veins or the artery? Arteries are weaker? Okay, the veins are weaker than arteries. So therefore, if you subject a vein in the same pressures as the artery, because there is no capillary buffer, okay, you went straight from an artery into a vein. So therefore, what will happen? It will eventually rupture. It'll overgrow first, just like a fistula, right? Have you seen people with fistulas for dialysis? It looks ugly, right? It looks large because the vein was subjected to arterial pressures because you connected them. So same exact thing here, but this one wasn't really planned out, right? Yeah, this wasn't like surgically planned. So this happens to be just, an anomaly. And then eventually, you'll grow old with an AVM, no problem. The problem really comes when you develop hypertension, because now the AVM cannot sustain the high pressures and it will eventually rupture. So what are the three risk factors again for hemorrhagic stroke? Hypertension, aneurysms, and AVMs. All right. So let's look at manifestations. So how will the hemorrhagic stroke appear? So they'll complain of the worst headache of their life, a severe headache that indicates severe hypertension. And as already described, because the rupture and intracerebral bleeding, intracerebral hemorrhage causes increased intracranial pressure. The brainstem is herniated out, it's pushed out forcibly out into the foramen magnum, causing changes in the mental status, level of consciousness. And because as the intracranial pressure continues to rise, then the patient will have a seizure. And these are the manifestations for ischemic stroke. It can vary. One stroke patient doesn't really look like another one. I mean, they do have similarities with unilateral numbness or weakness of the face, arm, and leg, okay, contralateral to the affected side. There's aphasia. We'll discuss a few terms later with aphasia. There are vision changes, not just vision loss. So it doesn't really go blind sometimes. It's just blurred vision, for instance, or partial blindness, meaning both halves of the eye are blind. Okay, so imagine a scenario wherein the left half of your visual field in each eye is blind. How will that look like? You can't see on the left half of your left eye. You can't see the left half of your right eye. What will it look like? How will your vision be? You'll have blind spots, correct? So you're seeing in front. I can see Matt. I can't see clergy. Okay, I can't see Mark. I can see Kurt. All right. So I have blind spots. Okay, so we call that homogeneous hemianopsia. Don't worry, the term will come up. Oh, it's already here actually. Sorry. Homonymous hemianopsia. Okay, so that's what the vision change is can be. Not all patients will have this. Some patients will have the entire eye blind, for instance, or both eyes could be blind, depending really on which part of the brain lost blood flow. Yeah, it's not really very famous. Well, it's quite common, but it's not really talked about because the patient will just say they're blind, right? Okay, that's ends the risk factors and the common manifestations. Let's go now to management. So I already described embolic versus thrombotic strokes. And manifestations. So here's a good select all that apply. The key here is in ischemic stroke, depending again if it's embolic or thrombotic, if you just add sudden in all of these phrases, say sudden numbness, sudden confusion, and so on, sudden, that's usually embolic because the evolution was fast, correct? The clot was already formed either from the leg or from the heart and then went in a few seconds, went to the cerebral or carotid arteries, blocking it depending on the number and size of those clots. Then therefore, the symptoms will occur suddenly. You were fine a second ago and then now you have them. The list of the deficits, motor sensory deficits, is in these two tables here. We'll get to them later. What's the difference between plegia and paresis? Hemiplegia versus hemiparesis. What's the difference? Okay, plegia is paralysis. Paresis is weakness. All right. So either one will occur depending again which part of the brain is involved, whether it's the frontal or the occipital lobe or the parietal lobe and which side. Communication loss. Let's differentiate a few of these terms. Dysarthria is a motor problem. Again, dysarthria is slurring of speech because of a motor problem. Okay, so let me give you an example. I'm totally fine in my brain, but my speech muscles after the stroke were affected. Okay, so some of my cranial nerves were affected and therefore cannot control my speech muscles. So I have dysarthria. Do you follow? Okay, so the slurring of speech here, is it because of a brain issue? No, it's a motor issue. All right, there's a big difference. So that's dysarthria. So therefore, can this be fixed by speech therapy? Yes, this can be fixed by speech therapy. Now let's go to aphasia. There are two types of aphasia, either expressive or receptive. Expressive, you have difficulty expressing, forming words, forming your thoughts. Receptive, you have difficulty understanding both written and oral or verbal communication. Okay, so it doesn't matter whether the communication is in text or spoken. I cannot understand it. This is a cognitive problem. You understand? Can this be fixed by speech therapy? No. All right. So when you see slurring of speech in a stroke patient, you have to distinguish, is this dysarthria or is this aphasia? All right. They're not the same. Apraxia is inability to perform a previously learned action. To elicit this is usually a command. Okay, you ask the patient to do something and they cannot do it. So let's say everybody knows how to sing happy birthday, right? No matter what language you speak, you have a happy birthday somehow in your language, correct? In your culture. Now, the patient will be making verbal substitutions for desired syllables and words instead. So that's apraxia. Perceptual, so I explained the vision change of homonymous hemianopsia. So this is blindness in one half of the visual fields in one or both eyes. And then there's sensory loss. When we say agnosia, agnosia is all five senses, meaning we have visual, tactile, auditory, or even olfactory agnosia. Okay, so you smell something, you see something, you touch something, you hear something, but you cannot somehow perceive what you're seeing, feeling, hearing, or smelling. Okay, you cannot. Previously you do, but now you cannot. So can this be a problem? Let's say you give them an object. This is not exclusive to stroke. You've seen advanced dementia patients? Okay, so some patients, that's why we give them a feeding tube. We put a PEG tube, we put a nasogastric feeding tube because they can no longer recognize the object. You give them a tray of food, they don't know what it is. Can you picture that? Okay, so that's what we call visual agnosia. So if they can't recognize food, will they know what to do with it? No. So therefore, they stop eating. Okay, and then that deteriorates. The patient who stops eating and no feeding tube, they're dead within a year or maybe the last 2 years most, because we can still force feed them, but they won't know unless they are fed. So that's why unless that patient has a advanced directive, meaning no, they don't want any feeding tubes, they will be given a feeding tube and they'll live indefinitely. Quality of life, of course, is different, right? I mean, you're just alive, but you don't know how to eat, don't know how to do anything anymore. Yes, Matt?
For people that had
no, because that is not a brain issue. That's a sensory problem, meaning somehow the olfactory nerves were affected, but your sensory function was not really affected. No. So this will lead to or greatly affect the patient's prognosis and outcome if the patient has cognitive impairment now. Okay, so if it's the frontal lobe that had the stroke, then learning capacity, memory, these are all affected. So patient literally becomes a vegetable, right? So, I mean, we've seen that, we've heard that term, right? So these are depending really. So one stroke is what I'm saying. One stroke patient is not the same as another. Really depends which hemisphere, which lobe was affected, right? And that will determine how this patient will, or whether or not they will recover and what kind of life they'll have. So who wants to have a stroke here? All right, so this is the most for me, right? So can it be prevented? Yes, so we named the risk factors earlier. We already studied them under coronary artery syndromes, acute coronary syndrome, sorry. So stop smoking, lose weight, eat healthier, be active, right? Manage diabetes better, manage hypertension, correct? Right, so we can prevent it. Not the stroke, but the atherosclerosis. Yes, the high cholesterol, that's genetic. So doesn't really, there's no excuse. You can prevent strokes, right? Because I mean, let's say if it's genetic that you have high cholesterol, like in my family, no matter what I do, even if I eat healthy, my cholesterol is just high. Okay, that's just how my body processes cholesterol. So I take statins, right? So there's no excuse, right? There's treatment for the risk factors. So here's the summary, table 62-2, and there's a second one under table 62-3. All right. So leave you responsible I didn't do the emotional deficits yet. Okay. So in emotional deficits, it was mentioned in the last paragraph also under frontal lobe, under cognitive impairment. Now, keep in mind that this emotional lability, meaning they go from being happy to suddenly sad to suddenly violent. Okay. The key here is the patient has no self-control. So how do you handle these problems? Can you use therapeutic communication? Like, can you do, let's say they went from happy and then suddenly anger, right? Can you do, hey, do you want to talk about it? Can we do that? No, because the patient has no idea why they're behaving this way. Okay, say this the stroke caused them to lose self-control, especially over these emotions. So how is this handled? So look at the interventions on the third column. So how do you do it? Do you see any although we do have here encourage patient to express feelings, but that's not really the main intervention. So if you look at the intervention, support the patient, discuss with the patient and family, know that they understand the reason behind these emotional outbursts. Then group activity, provide stimulation. So these are the interventions, right? That's all we can do. So provide a safe environment, meaning if needed, remove them from, let's say it happens during these group activities here. So let's say they're in this group activity and then they have this outburst. So is it safe to keep them there? Okay, do you have to explain it to everybody, each and every one? No, just remove the patient, right? Protect them from the self-esteem issue that can arise from this embarrassing situation, right? And then return them when the episode is over. All right. Let's talk about a TIA. Now, which one do you think a TIA is a transient, stands for transient ischemic attack, which means there was an interruption of blood flow. However, it resolved within 24 hours, some in less than an hour. So this is frequent. We get patients like this. We get stroke alert. They come in to the ER. They have stroke symptoms as listed in the table earlier or in the bullets we saw earlier. You know, the numbness, the loss of sensory motor function, the slurred speech, weakness or paralysis in one side of the body, the headache, vision changes. In all accounts, it looks like a stroke. But then, after an hour or so, or in less than 24 hours, the symptoms improve. Symptoms went away. They resolved on its own. That's what we call a TIA. Meaning, yes, for a brief period, there was interruption of blood flow. There may have been one or more clots, but did the clots remain? Somehow the clots dissolved or maybe too tiny to cause a permanent obstruction. So therefore, did the patient lose any brain tissue? No, because the interruption of blood flow was brief, right? Unlike a stroke wherein did any brain cells die in a stroke? Yes. Can you bring something back to life after they're dead? No. Okay. So the TIA again is what we call layman term, you know, a mini stroke. Okay, so yes, they had a stroke, but momentary, but not really. It's not a stroke because when we say stroke, it's an infarction. So is there really an infarction here? No, there was just temporary ischemia. All right, temporary interruption of blood flow, but no evidence of infarction. So after a patient suffers a TIA, what is the best approach? Because the next time, would it still be a TIA? Probably not. Okay, so we'll get to the management later. Now, after having a TIA or a stroke, are you immune from another one?
No.
The risk increases, okay, because you already had one. You may not be as lucky next time. So anyone with stroke or suspected stroke symptoms, let's say two scenarios: you came from the community, at home, at work, you're brought to the ER, or you're already in the hospital exhibiting signs and symptoms of a stroke. In both scenarios, patient, what we call a stroke alert. That means when that's heard by radiology, they will keep one CAT scan open. They will not receive anybody else. One CAT scan room must be open. No, somebody will say, okay, can we just squeeze this in? No. Stroke alert was called. One CT room must be open. Okay, we reserve that for that patient. So when that patient comes in, first thing we'll do is take them to the CAT scan, because we need to know what type of stroke is this. All right, is this ischemic or is this hemorrhagic? Remember, time is tissue. So each minute, each second we lose, if it's really a stroke, then brain cells are dying constantly. So within not really 20, the standard is 10 minutes. Okay. But this book says 20, but do you want 10 or 20? 10, right? Especially if it's your family. Okay, so within 10 minutes, get them to the CAT scan, and let's see what kind of stroke is this. MRI is better, but CAT scan is faster than an MRI. So initial MRI usually okay, but if the CAT scan is not conclusive, and then usually if it's inconclusive, that means the patient may have had a TIA, or maybe the stroke wasn't caused by a really large blood clot. In that instance, we will do a follow-up MRI, especially if the patient's symptoms resolve, okay, or start improving. Prevention, I already mentioned, but let's talk about a few. So therefore, we know the risk factors already: hypertension, obesity, high cholesterol, diabetes, right? Metabolic syndrome. So therefore, you give statins, correct? You give what else? Aspirin and Plavix, okay, antiplatelets, knowing this is caused by blood clot. So that's what we put. What if it's caused by AFib or aflutter? What will the patient take? Anticoagulants, right? They're on anticoagulants, heparin initially, and then either warfarin, depending what's causing the AFib. Is it valve problem? Then it's only warfarin. If not, then we can do the Xarelto, rivaroxaban, apixaban, edoxaban, dabigatran. Okay. For hypertension, then that's the DASH diet along with antihypertensive medications, aspirin, as already mentioned, and clopidogrel. Sometimes the patient will be on dual antiplatelet therapy. So if it's single, aspirin only. If it's dual, then it's aspirin and clopidogrel, right? You know what clopidogrel is, right? That's Plavix. Yeah, you know Plavix, but NCLEX again will only use generic name. So clopidogrel. All right, so here's your risk factors. We already mentioned. Yeah, we did all of them already. Management. So we discussed this a few weeks ago in lab when we demonstrated the alteplase preparation. So here are the choices. So for AFib caused by a valve problem, then it's warfarin only. This is the target, 2 to 3, INR 2 to 3. If the patient has a non-valvular AFib, then these are the options. What's the difference between these and warfarin? Why are some people placed on these? And why are some people using warfarin? Okay. Okay, the answer was pretty simple. The drug companies said so. So during their clinical trials, they put the sample patients, and they discovered that these drugs that I highlighted did not work to prevent blood clots in people who had valvular problems causing the AFib. Right? As simple as that. So they don't recommend these drugs if the AFib is caused by a valve problem. All right. So warfarin only. And you already know, can we use, let's say the patient has AFib now, can I use warfarin only? No, they have to be on heparin, right? Heparin first, warfarin will be given the same day because warfarin will take several days before it gets to 2 to 3. Meanwhile, they need anticoagulation now, not in 5 days. Okay, patient had a TIA, patient had a stroke, they'll get another one. So heparin first will be started. Heparin will give immediate anticoagulation. Problem is, can you send the patient home on the heparin? No, they have to go home on. Again, stop saying Eliquis. Eliquis is here. Eliquis is apixaban. All right. So what did I just say? If it's valvular AFib, we can't use these. Okay, the dabigatran, apixaban, edoxaban, rivaroxaban does not work. Okay, on valvular AFib. You know what is valvular AFib? AFib caused by a valve disorder. Are we clear? Felicia, did I clarify that? All right. So again, can we give warfarin only? No, it has to start with heparin. Heparin will give you immediate anticoagulation. Right now, once you press start on the pump, heparin's flowing, patient receives immediate anticoagulation. Warfarin, yes, they swallow the tablet, but how long does this take to reach to 2 to 3 days, up to 5 days? Sometimes we get lucky, we get it done in 3 days, sometimes 5, sometimes 7, sometimes 10. Warfarin, because each patient will respond differently to warfarin. I'll explain when we get to pulmonary embolism, because we'll talk about anticoagulation again when we get to pulmonary embolism. So aspirin, we mentioned, and clopidogrel, if the doctor feels they'll benefit from dual antiplatelet instead of a single. So here's the preferred therapy for ischemic stroke. There are contraindications, of course. I already mentioned the contraindications are in acute coronary syndromes, right? Because thrombolytics were also used in acute coronary syndrome, remember? Yes or no? Yes, remember I gave you a scenario where the patient had a heart attack, but the facility they reached did not have a cath lab. So what's their only choice? A thrombolytic, okay? Because remember, acute heart attack is caused by a blood clot too, affecting the coronary artery instead of the cerebral or carotid. So I already explained this in lab a few weeks ago. So this is given again within 3 to 4.5 hours. From when? From the onset of symptoms. Okay, so therefore is time important? Okay, so what's our decision if, let's say, nobody witnessed the stroke? Patient already came in, we have no idea when did it start. I don't know, we found her like this. So what do we do? Okay, we will make the best guess. Okay, best educated guess. So we'll contact any family member. Okay, so we'll create a hypothetical scenario. So when did you last hear from grandma? Right? So when did you leave the house? And when did you find them? If it's beyond 4.5 hours, then what's the decision? Do they still benefit from it? No more. Too late. The stroke is too old. It already killed whatever tissue that artery blocked. Then it's too late. I mean, it's dead. What are we saving? Nothing. Yeah. Alteplase, right? So RTPA or Alteplase, again, within 3 to 4.5 hours. I know it says 3 here, but there's a extension here by the American Stroke Association right here. So it may be extended up to 4.5 hours. All right. So the standard really is 3 to 4.5 hours. Yes.
But if, let's say when our regions do come in and we like calculate, we do our our investigation. So what do you do with that thing? You just like.
What do you mean?
Like,
The-
let's say it's already been past the 4 hours and a half.
Okay, they missed the window. Yeah, okay.
So then what do we do with that patient?
Nothing for this stroke, but can they have another one?
Yeah.
Yes, we still treat them for
So,
a future
but you
stroke.
don't do that.
We can't. I mean, it's too late. Yeah, so it's like this. So let's say this is the artery, right? And this artery supplies this computer, right? This is the brain, part of the brain that this artery supplies. So there's a clot here. It already killed this. Nothing else will die because the artery ends at some point, right? It ends to a specific tissue. Too late. Nothing we can do. That part, let's say, is the frontal lobe or parietal lobe. Right parietal lobe, for instance, it's already dead. I mean, nothing else will die. The clot is there. Leave it alone. I mean, there's nothing to save. It killed that part of the brain. All we want to do is prevent another clot from killing off another section of the brain. Okay, that's all that's left to do. So if the window was missed, sorry. Okay, there's nothing anybody else can do. Right? Unless, something resurrects, like Jesus, for instance, yeah, came back to life after 3 days. I don't think this brain tissue will come back to life in 3 days. Okay. There is a option of intra-arterial administration, meaning the thrombolytic therapy administration here is IV. Okay, this is intravenous. There's an intra-arterial option if the patient made it within 6 hours, meaning the patient has to go to the cath lab and the doctor has to administer it. The doctor will thread a catheter all the way to the carotid or whichever cerebral artery was involved, and then they'll inject a tiny amount of the alteplase straight into the artery. Okay, within 6 hours. That's the absolute last. But there are a lot of contraindications for that procedure. Okay, so again, so those not eligible for IV delivery may be eligible for intra-arterial delivery. Did I explain that correctly? Okay, so the limit there is 6 hours though. All right. Here are endovascular options. So this can do two things. This can both treat the acute stroke or also prevent future strokes. Okay, endovascular. So this is usually the carotid procedure, carotid endarterectomy. So they'll open the carotid depending on how bad is it. Let's say it's 90% occluded. So they'll be a good candidate for endovascular. They'll clean out the carotid, open it, slice it open, remove the plaque, stitch it back up. All right. So the key here again is prompt diagnosis. So within 10 minutes of arrival to the ER or within 10 minutes from an inpatient diagnosis, then the better the outcome. So we can totally, absolutely 100% reverse the stroke. Okay, if we make it up within 3 to 4.5 hours. There will be some deficits, but it'll go away after therapy. Rehab. So we'll put the patient in rehab, they'll regain the function. Again, what's the time period? 3 to 4.5 hours. So time is tissue. So here are your indications. So patient meets these criteria. You can also use this as if they don't have these, then that's a contraindication. Make sense? Okay. here. So you can see, look at the indication. So platelet at least over 100,000, no endocarditis, no intracranial hemorrhage, or no, you can also put no brain tumor, okay, or no head trauma within the last 3 months, no GI bleeding, because what will the drug do? A thrombolytic will do what? It'll cause bleeding. It will dissolve any clot that's inside a patient's body, which can potentially lead to hemorrhage. So dosing, we did this in lab, 0.9 milligrams per kilogram. Please refer to our discussion on how to do this previously. No, 90% over 1 hour, first 10% over 1 minute, right? What's the limit for the blood pressure? Before we can start, 185 over 110. Okay. This is for NCLEX purposes, all right? Some facilities will have different limits, but that's facility specific. Okay, you understand? So don't insist like, oh, the book said 185 over 110. The neurologist will knock your head, okay, for talking like that. All right, so follow agency policy. But for our NCLEX, what's the limit? 185 over 110. So this is the let me talk about permits. Never mind. Side effects, of course, is bleeding. So you always look for, it's easy to see obvious signs of bleeding, but can we see hidden signs of bleeding?
Yes.
That's difficult. So you should look for hidden signs. Let's say, how do we know they're bleeding in the GI tract?
The stool.
Okay, color of the stool, or if they vomit, right? Coffee ground emesis. Vital signs, like Kiara mentioned. Okay, so what will vital signs look like if someone's bleeding internally? Heart rate will, and blood pressure. Okay, so anything resembling the GI bleed we discussed for peptic ulcer patients. Glucose should also be controlled heavily. I mean, for obvious reasons, the patient already has impaired perfusion, impaired cerebral perfusion. You don't want to impair it more with the sludging of blood flow caused by hyperglycemia. So if the patient, again, isn't a candidate for TPA, then this is our management. So the patient will receive management of intracranial pressure. As I already mentioned a few weeks ago, we're not doing the NIH stroke scale. So which one will we use instead? Glasgow Coma Scale, which we had an activity already. I already explained the NIH stroke scale needs certification. It took me 2 hours to get certified. So the exam is about, there are 5 exams, they're all videos. So you're asked to score each patient in the 5 videos, and you need to score 95% or more. That's why. Okay. But if Felicia insists, I will oblige.
No, give it to us. Maybe for next semester.
Oh, and she wants to stay next semester too.
She wanted to long, give it to her.
Okay, guys, let's continue. So for all stroke patients, and this is not exclusive for stroke patients, these are applicable to any head injury, head trauma patient. because it's the same brain we're talking about and the same increased intracranial pressure that we are trying to control. Okay, so these are the interventions to control or decrease intracranial pressure. Oxygen. Must be kept above 95%. Now, the reason for this, the rationale for this is CO2 is a potent vasodilator. I repeat, CO2 is a potent vasodilator. And we already know what will happen to the brainstem when there is increased intracranial pressure. It's going to be herniated, right? It's going to be pushed down. So therefore, blood flow to the brainstem will decrease. And therefore, what will happen to the respiratory rate? It will drop. What will happen to the CO2 levels once respiratory rate drops? Increase. Now, again, CO2 is a potent vasodilator. What happens to ICP? If the blood vessels in the brain dilate, it will increase blood flow, increasing blood volume, increasing ICP. Make sense? So therefore, what's the best way to do that? To control it? Provide oxygen. Okay? Right. So if needed, we'll have to intubate this patient. If we can't keep the oxygen saturation 95% or better by oxygen cannula or mask or CPAP or BiPAP, then we'll have to intubate. Clear? Okay. Next, head of the bed elevation. It should not be greater than 45 degrees. So minimum 30 degrees, not lower. We also don't want the head of the bed higher than 45 degrees. So on the exam, if you see A, 30 degrees, B, 45 degrees, which one will you pick? 30, all right? Again, the 45 degrees is not mentioned here, but I see it on other textbooks. Other authors go 30 to 45. But if you see a test question on the NCLEX that says A, 30, B, 45, which one will you pick?
30.
All right. Now, the reason for this is what happens to hip flexion when you go higher on the head of the bed elevation? Hip flexion, what happens? It increases, right? So once you increase, so the 30 degrees will be like this, kind of, right? That's 30 degrees. If you go like this, 60 or 90, what happens to hip flexion? It increases, right? The angle goes higher. Now, what happens to venous return from the head back to the heart? Because now your abdominal pressure, what happens to abdominal pressure? The more you flex your hip, increases, right? Because now your abdominal contents will have to push against the diaphragm, correct? So therefore, what happens to intrathoracic pressure now? It also increases. So everything will increase if you flex the hip sharply. So hip flexion must be wide, okay? All right, so it has to be 30 degrees, or the most would be 45. Okay, so does this help control intracranial pressure? Yes, very simple, right? Simply positioning the bed 30 degrees, head of the bed 30 degrees. Hemicraniectomy is done. What is this? So this is the removal of a piece of skull. So surgical procedure, so they open your scalp, remove, drill a piece of your skull, take it out, sew the scalp back in, and then leave that skull somewhere in your abdominal wall. Okay, so we'll insert it somewhere in your belly. Okay, keep it alive there. But the patient doesn't have a skull in one portion of the head. Yeah. So therefore, what do you need to do since there's nothing protecting that? It'll look caved in like this. They look like they have a crater on one side of the head. So how do you protect that? Because when they get out of bed, they fall, what will happen? They have no skull. So what should you put on the patient every time they get out of bed? On a wheelchair or ambulating? A helmet, okay? I already mentioned intubation, mechanical ventilation if necessary. continuous hemodynamic monitoring. So the patient will have what's the only way we can monitor hemodynamics? What instrument do we need to insert into the patient? We did this last semester under heart failure. A pulmonary artery catheter, remember? All right, so this is a pulmonary artery catheter, which will monitor pressures inside the heart. All right. Blood pressure, antihypertensive treatment given to lower blood pressure as needed. Okay, so we don't want the blood pressure to be over 220 or over 120 diastolic. Frequent neurologic assessments. Okay, fever. Now, fever is common after stroke. This is just a normal response by the body to injury. Something died, correct? Yeah? Something died? Yeah, brain tissue died. So will that increase body temperature? Yes, as part of the inflammatory response. Now let's go back to vasodilation. If the patient has a fever, what will happen to blood vessels in the brain? Dilate. What happens to blood volume? What happens to ICP? What happens to brain tissue? Ischemia, right? So last, blood sugar, I already mentioned earlier, we don't want, because the higher your blood sugar, what happens to the consistency of your blood? Thicker. What happens to circulation to brain tissue? All right. So these are your interventions again to, what do these interventions do again? They will help manage what? Intracranial pressure. Okay, so patients with high ICP, these are your interventions. Don't forget these. This will apply when we get to head injury. Okay, complications. So you remember those two endocrine problems that result from brain trauma, stroke, or brain tumors? Now, fluid and electrolyte problems. Remember diabetes insipidus?
Yeah.
And syndrome of inappropriate antidiuretic hormone? All right. So if you have, please recall them because this is brain injury. Is stroke considered brain injury? Yes. Yeah, this is one of the massive brain injuries commonly occurring. So therefore, you need to monitor them for either diabetes insipidus or SIADH because what will the DI and SIADH effects be on blood pressure? Will it mess up your blood pressure?
Yes.
Yes. And do we need the blood pressure to be optimal for these patients?
Yes.
Yes. I'll just explain the CPP concept when we get to head injury, okay? Because it's not mentioned here. I already mentioned CEA. So CEA is carotid endarterectomy. So this is a option again to treat either acute stroke or prevent new strokes from happening. I described that this is the removal of plaque from the carotid artery. Can we do this on a cerebral artery? No, too small. Okay, so the carotid's huge, so we can do this on the carotid. Again, to prevent stroke in patients, but it can also be used to treat acute stroke. So here are the thresholds. So they're candidates if the carotids are 70 to 99% occluded. You want to wait till 99? Okay. So you typically here moderate are also candidates, 50 to 69. Or stenting. So this is similar to cardiac catheterization. You put a stent on the carotid artery. So here's the picture of the procedure. Let's look at your responsibilities after the patient undergoes this procedure. So this section, this whole paragraph. So monitor blood pressure, monitor the incision, medications to lower blood pressure. Can they get a stroke during and after this procedure? Yes. So monitor them neurologically constantly before, during, and after the stroke. So here, formation of a thrombus at the site of endarterectomy is suspected. I mean, these are stroke symptoms, correct? And here are more, because we're dealing with the neck. There are cranial nerves there, injury to the vocal cord, or these nerves here. 7, 9, 10, 11, and 12. Okay, you can disregard 62-5. These are way too many. So just stick with what's on the paragraph here. This is quite a long table. Right? See, there's a long list. Yeah, colon guard. Yes.
Is a shunt different from this?
Yeah, a shunt is like a tube, a connection. You're talking about to manage hydrocephalus? Yeah. A stent is you leave it in the existing artery to keep it open.
Forever.
Yeah. Of course, I mean, you can remove a shunt. Don't want to say forever, but yeah, I mean, they can fail too. I mean, a stent can also fail. Yeah, but same thing as a shunt. So shunt is to divert. Yeah. So main difference between a shunt and a stent, the stent you'll keep an existing vessel open, whereas a shunt you're creating a new vessel to bypass. Yeah. Did I answer your question?
Yeah.
So two they're different animals. They're not, they don't serve the same purpose. No, sorry, they serve the same purpose but work differently. So the rest of these are rehab, and that will take a long time, and we are not physical therapists, so we'll skip this part. Sorry, the eyes will have to do because we're the ones feeding the patient. So let's discuss the vision. Where's the vision? Somewhere. Exercise, ambulation. Okay, here. We'll have to participate in this one, enhancing self-care. Now, another motor deficit that will result is, how will you feel if your one side of your body is paralyzed, wherein you cannot move it and you can't feel anything on that side? So what could happen to that side of your body? You can't feel it, you can't move it. We call it unilateral neglect. Okay. So it's a syndrome common among patients with hemiplegia, right or left side hemiplegia. Paresis is better because they can still feel something on paresis, but plegia, I mean, total paralysis, that will result in unilateral neglect. So the patient is taught to touch and feel that side, and then when they put on the clothing, they always dress that side first, okay, before dressing the active side. But the important thing is for them to care for it, because otherwise that side of the body will feel like a shoulder bag. I mean, will you feel it when someone slashes the shoulder bag to steal your wallet? Can you feel it? Will you say ouch when your bag is slashed? Okay, that's how exactly that side of the body will feel. The next thing you know, that side of the body is already injured. There's an infection. They have another problem. With dysphagia, the first, do not feed the stroke patient within 24 hours until the patient is screened by a speech language pathologist. So, ST, the speech therapists have these patients as the priority. So if they have other cases, non-stroke cases, they'll be like second-class citizens. These are their priority patients. So stroke patients are seen first, evaluated first, and then the speech pathologist will recommend the diet, and the doctor is obligated to follow what the speech therapist recommends. Okay, they're the boss. And please don't risk it. I've had my share of, I was just in a hurry and I want to get it over with my medication pass, and the patient paid for it. Okay, so I thought the patient could handle this consistency of liquid or food. I forced it into the patient, and what happened? Patient aspirated. Okay, so don't risk it. Okay, so you see, especially if they're not conscious. Okay, never, huh? Well, they have a diet, but doesn't mean it's accurate because patient's condition can change, right? Right. So whatever you suspect, don't risk it. Okay, so don't put anything into that mouth, especially if they're not awake. Okay, the patient must be awake to take something. Are we clear? Right. So don't put anything into their mouth because patient's unconscious. So therefore, can they swallow? All right. So you know where that will go, to the airway. Okay, and then next thing you know, you've caused pneumonia already. So this document, let's say you can't give the medication, document that the patient is lethargic, unable to follow commands, don't risk putting anything into their mouth. Are we clear? All right. Here are bladder and bowel problems. So some patients will have incontinence. Just make sure you put yourself in these patients' shoes. These are life-changing events. Okay, so this could be a who are you in your family, Sasha? Who are you in your family? Like, what's your role in your family? You're the boss, right? Because you're the mom. You're the boss. Okay. So imagine what will happen to you if you have a stroke. What will happen to your family? Right. So can your husband continue to work while you're paralyzed at home? Okay. So this is what I mean by this is life changing. Okay. So let's say you're a mom. Some people, they're like the CEO of a big company, right? So more people are affected. Okay, so you, for instance, how many people in your family? 4, 5? Okay, so four of us, four of you, and then people. Let's say this administrator, right? And then they didn't have a structure, didn't provide for any contingent, measures if the CEO passes, for instance, or becomes incapacitated. So more lives are affected, right? So the company could potentially close, and then now multiple families are affected. Correct? Yeah. So it's put yourself in these patients' shoes. All right, and the families also. So you'll see a lot of angry family members directed at you. It's not you. Okay, it's nothing about you. These are just the how they react to the loss. Okay, they feel so helpless, and they'll direct the grief and anger, whichever part of the grief process they're at, they're directed at you. Okay, so just be understanding. Okay, and don't treat the patient like like don't talk like they're not there, because especially if they have dysarthria or they have aphasia, right? So sometimes I'm guilty of that. Like, I talk about the patient and forget, oh, hey, I'm right here, right? And you're talking like they're not there. Okay, so just be aware of that. Communication, these are the interventions on how to communicate with patients with speech impairment. Right here. So some of us complete because we're so impatient because they say the patient is very slow to respond, like, and then we're tempted to finish their statement, very condescending, okay, for the patient. So be patient. So here are the recommendations on how to communicate. So be aware of what type of aphasia the patient has. Is it expressive or receptive or both? Most patients have both. We call it global aphasia, which is a combination of expressive and receptive aphasia. Oh, we have a chart. Okay, that's good. We have chart 62-4. Just like with any other patients with reduced mobility, so put them on a turn schedule or air mattress. So here's the chart. Good. Select all that apply question. All right, we're done with stroke.